And so just to give the system-wide numbers briefly, we have tested a total, we've done a total of 753,968 tests. And we've tested 431,321 people system-wide. 68,428 are positive, or 15.54%. And at Baptist Memphis, we've tested 67,672 people. 6,973 are positive, for 9.94% total. Just to give a slightly different piece of information that we've not done before, and that is the variant testing. We've done 210 variant testing counts. And of course, that's been much more lately when we've looked at that. The latest count is 38 alpha variants, 170 delta variants, and as interestingly as any of the rest of it, 2 gamma variants in the system that we have seen. That really is something that I certainly keep an eye on as being one of those variants that has really no respect for the immunity from previous infections, and is just one more step down the road of a problematic resistance that we're seeing in the more recent variants. If we look at current hospitalizations, they are indeed up further today. They're at Baptist Memphis. There are 46 people in acute care non-ICU beds, and there are 22 people currently in the intensive care unit, for a total of 68 people in the hospital with COVID-19. And 9 of those 22 ICU patients are currently on the ventilator. At Baptist DeSoto, there are 33 non-ICU acute care admissions with COVID, and there are 5 in the ICU, for a total of 38, and 3 of those 5 ICU cases are on ventilators. So those are the numbers. They do continue to go up at a rate that we are not happy with, but that's what we're seeing right now. So happy to answer any additional questions.
Hey, Dr. Threlkeld, it's Corinne. How are you doing despite the rise of
a little hectic last day or two. Corinne, how are you?
About the same, but hanging in there. So you had talked yesterday about FDA authorization and whether that might make it a little bit easier for employers to require vaccinations for people. When do we expect that? I mean, how long does it usually take to go through that process?
Yeah, so it's interesting. I mean, the formal differences would be once you've applied for that approval and met the initial obligations for that, it only takes 2 months of data to get emergency use authorization. So it's that was obviously long ago met, and we have hundreds of thousands of those vaccinations ongoing. It takes 6 months of data to be collated, submitted, and then reviewed by the FDA and other committees to get to full FDA approval. So Pfizer and Moderna have both applied for full FDA approval. Johnson & Johnson has not yet. And interestingly, it's not just the FDA. So those that are worried about it just being a governmental situation and the politics of it, there's an independent vaccine advisory committee to the FDA that has to approve these issues along with the FDA itself. So they are indeed independent and can make their own recommendations and thoughts about it. Pfizer made that application on May the 7th, and Moderna did on June the 1st, I think. So the process is well underway. I think there was a statement made by the FDA that they would be making a decision by January 2022, although a lot of people would suggest that that decision could come as early as September. I know in working with some colleges and the like, there has been a thought about hoping to have that decision before school started, even to be able to kind of decide whether to require vaccinations for incoming students. That may not be quite in that time, but we hope that it'll be soon thereafter. It's going to be important for several reasons, of course, in terms of requirements of the vaccinations. But even if you don't go to that far in looking at compelling people to get the vaccine, about a third of the people in a reasonably large survey recently suggested that if this were FDA approved, that they would be more likely to move ahead and get the vaccination rather than just the emergency use authorization approval that we have right now. But my own feeling about that is a couple. I'm a little nervous about relying on those statistics because number one, I think people have made up their minds about these things. And so a lot of times I think people just say, well, I'm going to wait until it's fully approved. And once it's fully approved, I'm afraid they're going to kind of move on to another reasoning. when you make up your mind and try to search for information to support your opinion, sometimes that can make things a little difficult. But as I say, one would hope that people would be pretty inspired and ready to get a vaccination based on what we're seeing with younger hospitalizations, more hospitalizations, and death along the way. But I think we can hope for full FDA approval within a couple of months if we're fortunate.
Hi, Dr. Threlkeld. This is Shay with Channel 3. This really kind of dovetails into my question, actually. And when it comes to vaccine hesitancy, some people are concerned that those vaccines were rolled out too soon. They're nervous about the science behind it. What do you say to those people?
Well, I think there are two things about it. That is to comment on what the science really is, and then to comment on the science versus our science about COVID-19 infection. That science is pretty easy. It's really bad, and it's killed well over 600,000 people in the United States. And the science is getting better every day in that we're learning more about the long COVID, the so-called long COVID symptoms with respiratory problems, blood pressure, autonomic nervous system problems, and many others. So that science is becoming compelling that COVID-19 is a bad thing to have. In terms of the science of, I'll just speak to RNA vaccines because that's what most people talk about when they say that these vaccines have been too rushed. If you look at RNA vaccines, they have been studied in animals since 1990, I think was when the first study came out initially in mice about RNA vaccines. Moderna, the company that obviously makes one of the RNA vaccines, has been in existence since 2010 with the sole purpose of making an RNA vaccine. So this science has been underway for literally decades. And there's no question that it was accelerated dramatically by the kind of white hot intensity of scrutiny, of federal funding, of competition to try to reach these vaccines. But I think that the problem that people don't realize is what took so long for this to happen is not that there was some concern even particularly about the safety. There's always concern about developing vaccines and doing it safely. But the real problem that made it so difficult and took so long from 1990 until now is that RNA is a very delicate, easy to destroy molecule. It is not meant to last long in the body. We make some of our fight or flight reactions, things that we do in the body that make changes are based on brief production of RNA that's very quickly degraded and goes away. You wouldn't want your fight or flight syndrome to go on for 3 days. So some of these things, these molecules are quite quickly broken down in the body. And it's just been very difficult since 1990 to shepherd those little pieces of delicate RNA into cells to be able to do the things that we needed to do to actually do its job and make those proteins. It took the lipid nanoparticle technology along with the RNA technology itself to be able to get that RNA to its target and allow it to do its work. And you see sort of all many sorts of nonsense sort of claims. I mean, people will say, well, that this is not a vaccine. Well, of course it's a vaccine. And if we want to, and they'll quote the narrow definition of a vaccine is a piece of the germ that you're trying to vaccinate against, put into people and broken up, and so that it stimulates the immune system to make a reaction. That simply is a definition based on what the technology used to be. It's like saying that the definition of transportation would not have included the Apollo rockets or the space shuttle before the 1960s and beyond. So it's sort of a ridiculous objection, I think, there. When you look at these studies, another objection is that it was never tested in animals. Also not true. It has been. Macaque monkeys and others. There was just a special authorization because of the requirement to move forward quickly and the danger of this pandemic that people could do some of the animal studies and the early trials in phase 1 and phase 2 at the same time. That's not always done. But the point is the trials were done. There was no corner cut in the tens of thousands of people containing phase 3 trials where they look at the doses, they look at the safety, they look at the efficacy. So more scrutiny has been placed on this vaccine or these RNA vaccines than we have ever seen before. So I think that most of the objections to how fast this vaccine has come together is somebody merely looking at the calendar and not really understanding the difference between how long it took to put together a whooping cough vaccine and a polio vaccine and the abilities we have to move quicker through some of these stages. we're better at getting through those stages now, and the technology has allowed that. And the RNA vaccines now are opening up an entirely new avenue of therapies for cancer. I think I've mentioned before, there's a genetic disease that's already shown a trial that it's been cured by allowing RNA to get into the cells and make that protein that they are missing. So, I mean, it's a very exciting time for vaccine technology, and that advance in technology has allowed things to move faster. But I think I think it really is the case that this has been more scrutinized than any process in the past. And look, I mean, I can only tell you that I'm comfortable enough to have taken it myself and to give it to everybody in my family, and I'm not sure how I can vote any more strongly than that.
Thank you.
Can you talk about booster shots, the Pfizer study that came out today? And when can we go get them? Mama and I are 5 months.
Yeah.
We got our second dose.
Right. So well, even if it is approved for that, and that's being looked at to be sure, I think the Pfizer data suggested after at least 6 months post second vaccination. So there's that. But I think that the booster shot is a very interesting sort of problem. Of course, the companies that make booster shots are going to be full on board with the idea that booster shots are necessary sooner than later. But when you really look at the data out there, we're not quite at the point of saying that our immunity has waned in the sense that our antibodies are going down and we're losing immunity to what we were vaccinated against. Now, it is the case that the virus is not sitting around waiting for us to vaccinate everybody. They're making changes of their own, and they're migrating and mutating away from the original virus that we used to build the vaccine. So that virus is moving away from our immunity slowly, thankfully, but surely. One vaccine doesn't help much anymore. We're getting clinical breakthroughs, but only mild ones in the vast majority of situations. So there really is no great clinical data yet that we need a booster. Now, there's some data that Pfizer points out that some of the antibody levels are waning in a couple of studies. But that even is controversial. There are data from Canada, the UK, and other places that show that the immunity is maintained very nicely, 80+% out at 6 and even to 9 months. So there's very much, it's very much in a gray area of when that's going to be necessary, particularly in a normal immune system person who got a good response in the first place. Now, that is being looked at very carefully, obviously, by the FDA, the CDC, the NIH, and others to try to find out when that's going to be necessary. Now, right now, these vaccines, as we have talked about, are under an emergency use authorization. So interestingly, Mississippi has been very aggressive about suggesting a third vaccine or booster to those who are immunosuppressed. And that is its own special category that goes beyond what we're talking about with immune normal or immune competent people. If you're talking about immunosuppressed people, they're folks who we show in a lot of studies now, fairly smallish, but several studies, that many of them don't make much of any antibody to begin with, and some limited antibody. And in several small studies, we've seen that a third shot does seem to help anywhere between a third and a half of those people who didn't have a response in the first place. By no means is everybody boosted up into an area of good immunity. And further, there's a big cloud over this that people don't realize, and that is that nobody really knows what to do with a level of antibody anyway. They're trying to do studies in England, which are also their own ethical dilemma that we've mentioned before, where they actually are challenging people with actual coronavirus who have either been vaccinated or infected, and they're trying to see what level of antibodies in people's blood actually protects them from the virus. So only then would we really know what a 75 level of antibody is compared to a 25. We don't have the answer as to how important that is between the two. So antibody levels going down a bit over time, it is unclear what good that's going to do. I think we're likely, the way things are moving, to see some approval of a third vaccine dose for those who are in fact immune suppressed and didn't get a good reaction out of the first vaccine. But I think despite the recommendation by Mississippi to consider giving a third vaccine to those people who are immunosuppressed, and they have made just that, the recommendation is for a consideration. Now, who is immunosuppressed? Well, an advanced HIV patient who's not on therapy, someone who's gotten chemotherapy for lung cancer, breast cancer, or blood types of cancer, so-called hematologic malignancies like lymphoma or leukemia. Particularly the chemotherapy-like substance rituximab is one that has really been very difficult and caused a lot of impairment of immunity important to the defense against coronavirus. People who've gotten rituximab have done, on average, very poorly with COVID-19. So those are the people that we're talking about who are immune suppressed. But despite that recommendation to consider it, the emergency use authorization doesn't allow for it. So if you're a physician and thinking about giving a third vaccine to someone, you're kind of on your own because there really isn't that allowance. And part of the reason for that is that it's helpful not to have people running around all over the place doing different things, so that we can get a better idea over time as we gather data on these vaccines in that people are doing relatively the same thing. And that's one of the reasons behind that. So it won't at all surprise me if we come out with an allowance for a third shot at some point for immunosuppressed people, and they are clearly studying it in immunocompetent or normal immune system people as well. But it is not yet at all a slam dunk that we're going to need it. I think that it's almost as likely that we will need a different vaccine to account for these variants as the virus continues to move away from us. And just one other sort of corollary point, right now, the virus is under genetic pressure here. The faster horse wins, as we've said many times. If you come out with a virus or it mutates to a virus that's faster and more efficient at replicating and spreads to people faster, it binds to our cells more tightly, it just causes infection farther and faster and more efficiently. That's going to take over the world. Alpha did it to the Wuhan variant. Delta did it to the Alpha variant. But there are other variants out there too. And as we get more people who are partially immune, either with natural infection or mostly immune with vaccination, it's going to put genetic pressure towards some of these other variants, like the Gamma variant that we said we'd seen 2 of in the Mid-South in our system, because the advantage then to a virus will be to be able to outsmart our immune system, not necessarily to be faster and more efficient. So that's what we fear if we're getting people partly vaccinated and not everybody, and we're still having a lot of viral replication, that it will allow for that virus to sort of make those changes over time. So we want to get people vaccinated with their second shot, everybody, if we can. And we'd be so much better off to do that than to have small numbers of people getting third vaccines. But a lot more to come on that as we look at the data about what benefit there really is in that third vaccine.
Dr. Threlkeld, what's your reaction to hearing that there are only 39 open ICU beds in the entire state of Arkansas? I know we've kind of been through this song and dance before, increased hospitalizations, low hospital bed availability, and then how might this affect the Mid-South and us here in Memphis?
Well, the Memphis part of it is a very good point. It might affect us significantly because, as we've talked about many times, we are at the center of a bullseye that goes about 100 miles in every direction: Western Tennessee, Eastern Arkansas, North Mississippi, even into Missouri. And so we've had transfers in the last few days from Missouri and Arkansas to our ICU. So that capita in Memphis, way more than a lot of other cities in America. You go out to some of the places in California, and they've got a lot more people per hospital bed than we do. Memphis has always been a big hub of hospital beds and availability. But you're exactly right. When you start having to transfer in people who need ECMO, artificial lung technology support, or aggressive sort of intensive care, it certainly down the road could put pressure. It has not yet here. But we would be foolish not to be looking at that and to consider that. We have a lot of ECMO technology here at our hospital. We have a lot of units. We have made that, we've expanded that capacity significantly during our first little tour of duty with COVID. And so we have a ways to stretch here. Certainly ICU beds here, they vary a lot and they run fairly high all the time. But part of that is elective procedures. It's things that could be changed at any time if we had to. We haven't had to think about that again. We've done it before. We can do it again. But you're exactly right in that we are definitely in the bullseye of everything that is going on for 100 miles in every direction. And I hate to tell you the news that the things that are going on 100 miles in every direction are not good. And they really are being overrun to a degree in Mississippi. In Arkansas and Missouri particularly. But once again, we have the solution. It is to get the vaccine. But as we talk about all these bad things that could happen, and I've certainly said many times, I don't expect us to get to the inpatient numbers that we had during our first kind of run with this, but I'm not as confident as I was before either, because these numbers are shooting up a little higher than I would have imagined. It never before has made any more sense than it does now to go get the vaccine. If you start with a J&J, it's going to take you at least 2 weeks. If you start with an RNA vaccine, it's going to take you 5 weeks to receive the immunity and protection from those vaccines. Do not wait until things are that bad. And again, not to belabor the point, but we still have people, have multiple people in their 20s in our ICU, certainly in their 30s, 40s, and 50s. So our numbers are up. They are in very young people, and none of them at this point that I'm aware of really at all in the hospital right now have been vaccinated. There may be one or two that sneaked in that I don't know about, but by and large, everybody sick enough to be in the hospital has been vaccinated. And that's how we protect Arkansas and Missouri and Mississippi, and certainly us in Memphis, who will probably, as you mentioned, pay some of the price for the illnesses that are going on there too. Any other questions?
Yes, I am sitting in for Dominique Dillon. I'm her photographer.
Oh, great.
I have 3 quick questions.
Okay.
Let me open my phone back up. Hold on. See if I'm pronouncing this right. What is monoclonal antibody therapy?
Yeah.
Who is eligible for it? And how much success has this treatment shown?
Yeah. So something that we were actually maybe in our clinic here at Baptist Memphis may have been the first people in the country to give it once it became available, or right at it, certainly. We had pre-built a facility with negative pressure rooms to make the administration of that safe and the care of COVID-19 patients safe for other people that might be receiving therapy here. So what it is, and we've, I think November the 16th may have been the first date we were able to give that monoclonal antibody. It has reached a couple of different brand names. It started with bamlanivimab, unfortunately an antibody that has become a bit obsolete because of some of the resistance of the virus. We've moved on to the Regeneron products by and large, and there are others now becoming available. But basically, it takes an antibody that someone would have made against this virus, and they choose an antibody that's one of those little Y-shaped proteins that sticks very tightly to a piece of the virus, in this case, the spike protein that we talk so much about, and it inactivates that virus. It puts it completely out of business. We call it a neutralizing antibody. And in some of these mixtures, they have more than one. They may have 2 different monoclonal antibodies packaged in the same dose. And so basically what it does is it does a very large scale version of what our immune system is trying to do in a slower version. And it's basically the idea of it's an immune response that you pour it in and it works, as the commercial goes. So it binds that antibody and neutralizes it and keeps it from causing illness. What it has been shown to do over time is to keep people who are sick and at high risk for progression to severe coronavirus disease from, in fact, making that progression. So someone who is pregnant, immunosuppressed, elderly, immunosuppressed, morbidly obese, anybody in that. And of course, the age has actually gone down now into the 50s to qualify for that. And so it's much more open to be able to give it to someone that it used to be. But someone who is at high risk of progressing to more severe illness, giving this early on particularly can prevent that from happening in a significant percentage of people. So we've been using it very successfully since the very first hour it was available to be used in the United States. And I think it's probably being underused now. So anyone who is positive in one of those high risk groups is eligible to get it. What is a little more controversial is whether it would need to be given in someone who's been fully vaccinated. If you have your own antibodies and are not likely to get ill at all, and we've said that many times, not many people at all get sick enough to be in the hospital. This monoclonal antibody is designed to, in fact, prevent people from getting sick enough to be in the hospital. So you may already have what you need. So how effective or necessary it is in someone who's already been fully vaccinated is a different, harder question. But certainly to somebody who hasn't been vaccinated or is immune suppressed and might not have had a good response to that vaccine, despite receiving it, they would be a primary target for this therapy. And it is, it's been shown to be quite successful, and we're giving it, I think with a great deal of success as well. Any other questions?
Yeah, it's Corinne again. To follow up on that, you know, as you see, I guess we don't sequence every sample, so you can't know if everyone in the hospital has the Delta variant. But just, you know, given the, I think 80+% of most COVID cases locally are the Delta variant, I guess we can assume that most people at Baptist in your ICU have Delta. Are you seeing any treatments that you used 6-7 months ago that don't seem to be as effective now? How are you adapting your strategy for how you treat COVID patients?
Yeah, so there are a couple of things. I mean, just the last topic, the monoclonal antibodies aren't as effective now with some of the newer variants, but that doesn't really come into effect in hospitalized people, because once you're hospitalized for COVID, it kind of is beyond what the approval for that particular therapy is. So in large part, and yes, almost everybody is a Delta variant, particularly in the last week or two. So one of the questions on the feed yesterday was, you know, why aren't you testing? The test is only for COVID. It doesn't test for the Delta variant. And it is true that it's a simple add-on test to do for the Delta variant. I'm not doing it much anymore because, as you point out, we already know that essentially all of them are Delta variant. And it is important to say that we're not aware of any major difference in how you should treat someone with a Delta variant of COVID-19 versus an Alpha versus the Wuhan, in fact. Now, they're more contagious. You need to stress to family members that they are unlikely to escape infection if they are living with someone with this infection. And even vaccinated people may become infected and therefore potentially infectious to someone else. Now, again, vaccinated people aren't likely to get sick at all, and they're less likely to give it to other people because they're not putting out as much virus to someone else as an unvaccinated person would do on average. But in general, I would say that the things that we've learned, and there are many of them in our first, as I say, tour of duty with COVID-19, most of those things are still effective and are not significantly affected in actual therapy of an individual patient based on which variant they have had. I mean, I think back, and it's the sort of thing that you just sort of forget, even as we stand there treating people at the bedside now. When we first were treating these people who were typically 70, 80 years old, coming in critically ill, rapidly progressing after 7 or so days of illness, we had very little to offer. I mean, we really did. Remdesivir wasn't available. We didn't yet know that steroids would be helpful. We didn't even know that they wouldn't be harmful at that time. So we were in a supportive care mode that was extremely frustrating and frightening to patients and, frankly, to healthcare workers too. We didn't even know how likely people were to get it from someone else from taking care of them. So there were so many questions that made the fear factor of this situation much, much higher early on. We have a lot more confidence in what to do for patients now. It is reasonably regimented. You can go to the National Institutes of Health treatment guidelines, and they are fairly straightforward. And they were updated just this month. And so we have remdesivir, we have steroids, we have tocilizumab and other immune modulators for people just as they are getting sick. Just as they require a lot of oxygen or go on the ventilator or move to the ICU, you have a little window there that optimizes when you give those drugs. We had no idea of such things. We didn't even have the medications then to be able to use, at least in this venue. So we have a lot better idea now of what to do and when to do it. It happens to be the Delta virus we're facing now as we've gotten that better idea, but I don't think there's any indication that we're doing anything differently other than trying to be extra careful and making sure that people don't spread it. And make no mistake, we see a lot of spread. And because of our own success with the vaccine, a lot of it is asymptomatic and a lot of it is minimally symptomatic. And I would caution people, please, if you have the sniffles or what you think is a mild sinus infection, please get tested, because that's all you're going to get if you're one of the many people who is vaccinated and protected. So again, the short answer is there's not much that we do differently for the Delta virus versus the Alpha variant. There's a lot we do differently compared to the Wuhan strain that came out, just because we've learned a lot about what to do. And again, particularly when to do it, because a lot of this is compartmentalized. What works in the first few days does not work once people get sick, and vice versa. And sorry to springboard to one more point, but to repeat what I said yesterday, if you just have a mild version of this virus at home, sniffles, even fever and not feeling good, the recommendation is not to take steroids. So if someone advises you to take a steroid for this infection early on, there is concern that that could be harmful. There are a few cases in asthmatic patients where they're wheezing enough and the breathing treatments don't really fix the job. Maybe they have to take steroids. But I would certainly ask the very pointed question to someone who suggests that you take steroid, isn't that recommended against by the National Institutes of Health and others? So we want to make sure that we give not just the right therapy, but the right therapy at the right time. Any other questions? I promised yesterday to give a little data on pediatric stuff, and I did not have those data at the moment. And Dr. Jake Lancaster, our crack physician who runs all things statistical for us, provided me with a little bit of a graph. I think most important probably are the ones that have started since the beginning of June. And at our pediatric facilities, there have been 295 people present to our emergency departments to test positive for COVID-19. There have been 3 inpatients in June and July and 5 outpatients. So for a total of 303 people between the age of 10 and 19. If we go back from the beginning, there have been 856 people diagnosed in those age groups, and a total of 25 hospitalizations, 35 dealt with at outpatient clinics. So obviously our numbers are significantly lower than what we see in adults. But some of those people have been sick, and a couple have even required transfer out to regional centers for some of their complications. So obviously we want to avoid those as well. Just answering a couple of questions from the feed. Lori Smith asked, at what temperature or degree does the Delta variant die? Last year in July, the COVID had died down at 80 degrees or so, and we were wondering if the second wave would even happen. And it's a very good question. It's not clear what temperature in the ambient air really is the limiter. In general, viruses like cooler climates, but we had plenty of viral replication in cases last summer, and I remember very clearly people saying, why hasn't it gotten better? And I remember thinking, well, maybe this is better. We may very much want this once we get into the cooler weather. So it certainly does not eliminate it. It did not do that last summer. And it's a little chilling when you think about the fact that this is happening in sort of the hottest part of our year in late July. And it does make you worry about what kind of numbers we could think about. Nancy Roper asked, why are you not recommending vitamin C, D, and zinc? And the short answer to that is that I'm certainly happy for people to take it, but the data are very sparse that they are effective. The little data on vitamin C and such really is extrapolated from data from sepsis, general sepsis studies. And those numbers are controversial. They're not very well worked out. And we really don't have any substantial data that these agents work in COVID-19. As I say, most people have no objection. A lot of hospitals, including ours, actually give it because it might help. But we really have no hard data, and the National Institutes of Health treatment guidelines do not recommend really for or against using them. One thing I would caution you, though, is be careful of side effects. Zinc is common to cause nausea. It also protects against the common cold, but unfortunately, in a lot of the studies that showed benefit against the common cold, you had to take enough to throw up in order to get that benefit from the common cold. So choose your poison in that situation. I think you don't have to really, I wouldn't tolerate a whole lot of side effects from any of those agents because the overall upside is not at all proven. Rebecca Lockhart asked an important question: are vaccines safe if you have had Guillain-Barre syndrome? The general answer to that is yes. Now, if you got Guillain-Barre from a flu shot, then some people would recommend that you not take a flu shot. So there's no real evidence of cross-reactivity of Guillain-Barre syndrome. There have been a few cases documented, certainly after COVID-19. There have been the vaccine, and syndrome and Guillain-Barre syndrome and neurologic temporary weakness sort of syndrome is almost always essentially completely reversible. So there's no reason that if you've had Guillain-Barre from a viral infection or some other problem in the past that you should not or could not get the COVID-19 vaccine. Barbara Robinson asked, Delta virus, where did it come from? I don't think this is the same question as where did coronavirus in general come from. Obviously, that's debated. We think it is, but it does raise an interesting point, and that is that these variants are nothing more than descendants of the original Wuhan wild-type strain. They had mutations. They always make errors in their replication as they make copies of themselves. Most of those areas do not lead to viruses that are viable. Most of them can't infect you, but a few can, and a few can even be more efficient at infection. That's what we're seeing. An important point is that Wuhan did not mutate into alpha, then to beta, then to gamma, then to delta. That's not the way it worked. They all sprang out independently if you look at the genetic analysis of their RNA. So these mutations, some of which they all share, by the way, or many of them, they are probably mutations that just happen to be advantageous. And when they occur, they give a higher likelihood of survival to the extent that we call viruses alive in the first place, but they make those viruses more effective. But it's not the case that they've gone down a single stream. So there are several springing off at one time in terms of these potential mutants. And that's a problem because it makes it easier for them to occur and more possible for us to get variants down the road that might be really even completely resistant to vaccination and the therapies that we have. That is possible. After all, the concern was that we were worried that would happen with resistance to past infection and more contagious. We were worried about that in the beginning, and that is, of course, exactly what we are seeing. Susan Mills asked, would you suggest wearing a mask while out in large groups? I have been vaccinated. The key word there may be out. If you're out in large groups and outdoors with great ventilation, that I'm not too worried about masking. I think that's largely a safe activity, probably for vaccinated and unvaccinated, though there are still some recommendations if you're closely packed into a stadium and you're unvaccinated that you may want to continue to wear that mask. I think outdoors is by far the safest environment, and it gives you much, much less risk. I think that's all I have for the feed. Any other questions? Okay, thanks guys. Have a good weekend.
Sorry, if you have one more second.
Yeah,
Chris,
yeah, of course.
I just got an email as you were talking. Not sure if this was someone who was watching the feed or not, but she wanted to know if you get the first shot of one of the mRNA vaccines in your right arm, does it make a difference if you get the second shot in your left arm?
Okay, so the question is, does it matter which arm you get it in for each shot? Is that what I heard? Essentially,
yeah. So can you mix arms from first to second shot?
Yes, you can. There's no need to put it in the same arm. I think if I may give my own experience, I figured there was higher chance to have soreness and side effects with the second shot. So I'm left-handed, so I took my first shot in my left arm and my second shot in my right arm, so that if there were more side effects on the second one, that it would not be in my dominant arm. It's what I did. I didn't have any significant side effects in either one, but not that that was not necessarily a fantastic move, but it does not matter really which arm you get the vaccine in. Okay, thanks guys. Have a great weekend.